I will be discussing this on behalf of the rest of my study team. So the study team was led by Dr. Charlene Dong. She's a resident at UT Southwestern who will be presenting it. And Dr. Gurbaksh Kaur at UT Southwestern she and I joke, we're partners in crime in this mission to kind of better tailor how we dose our treatments in myeloma, is a senior author on this. In brief, as all of you are aware, there is a big disconnect between how we dose proteasome inhibitors in myeloma in trials versus in real-world practice. Those of you who have seen me give interviews to Vijay Hemang before know that last year our target was bortezomib with Velcade, and we showed very clearly, for example, that once-weekly bortezomib performs just as well as twice-weekly bortezomib. 2, once-weekly bortezomib in real-world data has less neuropathy than twice-weekly bortezomib. And 3, around the world, 90+% of physicians prefer once-weekly bortezomib for their patients. And so we're hoping to move the momentum on that. And actually, interestingly, IFM 2020-05, the benefit study was presented, ESA VRD at ASCO. We can't take credit for that, but they used once-weekly bortezomib. But the tide is slowly turning, and that's excellent to see. Now we've turned our eye to carfilzomib, which, as all of you know, is more typically used in the relapsed refractory setting, might be used in high-risk patients, typically does not have the neuropathy risk that bortezomib has, but has a risk of hypertension and cardiac and sometimes renal complications as well. And so the tricky part is there actually is a randomized study of once-weekly versus twice-weekly carfilzomib out there, the ARROW study, but that was a once-weekly 70 mg per meter squared versus twice-weekly 27 mg per meter squared, and showed that once-weekly dosing was better. However, we typically don't use those in many of our trials of real-world practice, or else we didn't think that we did. In my practice, I typically use carfilzomib 56 mg per meter squared once per week, versus, for example, Candor and Ikema in the relapse setting use 56 twice per week. And so it's really complicated. As much as I like to say that bortezomib is complicated, carfilzomib dosing is even more complicated. So what we did is we leveraged the Flatiron Health database to really look in the real-world setting for U.S. patients with relapsed or refractory myeloma. We didn't look at frontline. What are they actually doing, and how do they do? And how did that change over time? And so here we ended up identifying almost 500 patients with carfilzomib in the relapsed refractory setting. Any number of partner drugs. We saw KD, we saw KPD, we saw quadruplets as well. And couple of trends that were interesting. One, as I was kind of just saying right now, our suspicion was correct that once weekly dosing is definitely becoming the norm. Once weekly 56 mg per meter squared now is, I think, 20-30% of patients receiving carfilzomib are receiving once weekly 56, and that proportion is going up. Interestingly, those trends were happening even before the COVID pandemic. With bortezomib, we found if you look over time, there was a steep adoption of once weekly bortezomib with the COVID pandemic, presumably because people didn't want to spend time in clinic. Here, even before that, I think people were realizing once weekly is the way to go for our patients. Might be better in terms of toxicities, definitely better in terms of time toxicity, right? Instead of coming in back-to-back days, 3 weeks out of every month, you only come in once per week for that time period. And then, more importantly, we looked at outcomes. This is real-world progression-free survival. The Flatiron database is actually pretty good at identifying progression-free survival. In brief, no difference between the curves. It's funny because at most of these conferences, all of us are looking for difference between the curves, trying to show that one regimen is better than the other. Here, we show they're all exactly the same. K56 once weekly, K56 twice weekly, and K70 once weekly. Unfortunately, the toxicities were pretty much the same between all of them, and it's unclear how well they were documented. About a 5 to 10% incidence of, for example, documented cardiac failure that we could pick up with our real world data. So that's maybe not as robust as a randomized study would be able to accomplish. However, just looking at things as a whole, I think this kind of shows that it's very practical to implement once weekly K56. That's been used in a lot of the frontline trials. Anything from Ischia to Master study to Manhattan have used K56 once weekly. In the relapse setting, again, if you look at Candor and Ikema, they're typically doing 56 meter squared twice per week. Our study suggests that 56 per meter squared once per week is the way to go. And if you just take things as a whole, same PFS, even if the toxicity are the same, once weekly dosing means that much less time coming in clinic for an IV infusion. I think our patients would say, yes, please.